The next talk is by Dr. Haripriya Aravind, and she'll be talking on techniques of pediatric capsulorhexis, enlarging a rhexis, retrieving a running out rhexis. We think pediatric cataracts are like any other cataract. We are mistaken. Go ahead.
Thank you, Dr. Sudeep and Dr. Minu, for this opportunity. So the lens capsule, as we know, is the thickest at the anterior and posterior pre-equatorial area. It's about 20 microns, and it's thinnest in the PC central pole. It's about 2 to 4 microns. Now, the anterior capsule, it generally increases with age. So in a newborn child, it's about 4 millimeters. It becomes about 20 to 25 millimeters by the time someone is in their adulthood. So what happens is, in a child, you have to remember that being a very thin capsule, this also tends to be very elastic. So I'll be sharing the part about how do you manage an intumescent cataract rhexis. So this is when things go well. In intumescent lens, as you know, sometimes you're not sure, but you find that the intralenticular pressure is not much, so you're able to do a complete rhexis comfortably. But not always you will have this advantage. So one has to remember to always stay in the capsule, use a good cohesive viscoelastic, and I'll be showing my technique of how I would deal with this intumescent lenses, either by doing a double rhexis or by doing a spiral technique. So once you do have the small nick, the primary nick has to be very small according to me. This way the initial rhexis would also be small, and this reduces the chance of extension of the capsulorhexis when you have this raised intralenticular pressure. So use a high molecular weight viscoelastic, and I would like to go in through the main wound, and then after the rhexis is complete, this is not adequate for phaco and lens placement. So I'd like to do a complete hydrodissection right after the rhexis. Now because we have the capsule stain and there is contrast, one does not need to worry about the visibility. So after this, you can go ahead and make a double rhexis. Now your interlenticular pressure is reduced because the hydro is complete. And then you make a small nick with the vanas and then go ahead and enlarge your rhexis. And most of these capsules are friable, being an older age, so they don't tend to run away unless your interlenticular pressure is still high. So once that hydro is done, then this should be fine because you also have a good visibility and contrast. In another situation, one may also consider doing a small rhexis but enlarging it towards the end, what we call as a spiraling technique. So in all these intumescent lenses, one uses a rhexis forceps, so please invest on a good Utrata. So this one is from Epsilon and is a Haripriya forceps, and this works very well to a 2.2 as well. So you towards the end, because you still have a well-formed chamber, you can go ahead and use the same flap and make it a little larger. So you don't have to close it. If the pressure is high, you can make a small rhexis and then enlarge it later. Otherwise, towards the end, continue with the same flap and make it larger rhexis. In spite of some of the best efforts, like this is a patient with silicone oils, a lot of vitreous upthrust. So the rhexis is being initiated through the side port. So you can see that the anterior lens surface, in spite of using a good viscoelastic and initiating it from the side port, there's a lot of pressure in the eye. And you do have a situation where, in spite of our best efforts, the capsule may go out to the periphery. So the Argentinian flag sign can happen. So one can handle these cases by just, you obviously don't have the chance of doing a rhexis now. It's not a continuous tear, but you can create more space and make a nick in the anterior capsule flap and then just close it. So this way you have at least a circular space in the center. Now having the rhexis having done at 2 points, it still is okay to continue with phaco, but please remember we don't have an intact rhexis. One can either go in through the main incision or go in through a paracentesis and make these micro nicks with this micro forceps and then make a larger opening in the anterior capsule and then continue with phacoemulsification. Now, in case the rhexis tends to run out, so the previous case we saw there was nothing one can do. It just splits in the center and it goes out. This is what you see in intumescent cataracts. But in other patients, sometimes things seem to go well, especially if they're younger, like patients who are at third or fourth decade. We would think their capsule is the same thickness, and we would go with a routine amount of tensile force, but what you will see that the rexis may go out. At this point, the Little's technique is very useful. With the Little's technique, one will have to grasp at the edge. In case you find the rexis is going out, one will have to grasp with your rexis forceps towards the edge of the flap, hold it, and then pull it backward. What the technique described is called centripetal force, which is more towards the center. But I would go a little further and say try to pull it backward, and this will change the direction. So you will see that if you do this, almost always you will be able to complete your rexis, unless if your nucleus is already been removed, you have the empty capsular bag, or you have a hypermature lens and you don't have that nucleus in the bag, there you'll find it's difficult. You may have a torn rexis. Otherwise, if the nucleus is still there, Little's technique works very well in most cases if you're able to hold on to the edge of the flap before it extends. Now, this is again an intumescent cataract, an SICS incision. The primary nick is made. Again, it's a large flap. It's tending to go out. At this point, one has to resort to using a forceps, go towards the edge, hold the edge of the flap, and you can see the movement. It's pulling backward, not forward. So normally the rexis you go forward, but just look at the tip of the forceps. You don't go forward, but go backward. I'll just show that clip once more in a little slower motion. So just watch the movement of the forceps. So by pulling it backward or centripetal forces, you'll find you can change the direction of the advancing edge of the rexis. So that is the movement one has to take when you find that the rexis margin is extending to the periphery. This way you can retrieve most of the extending capsulorhexis, unless it is something like an Argentinian flag sign where it's already gone out all the way. In a pediatric rexis, again, staining is very important because most of these cataracts are either lamellar, in which case again you're not able to see the rexis edge, and they are total cataracts, so it's very important. And a cohesive viscoelastic, even more important in a child because they also have low steral rigidity and the eye tends to collapse. So you'll have to have a good viscoelastic, and you tend to have a lot of which is upthrust. So investing in a good viscoelastic is very important when taking care of a pediatric capsulorhexis. So in a child, we always go superior and always go sterile corneal because of the low steral rigidity. Never go clear corneal in a child. Again, make sure that while the anesthetist is, has intubated, you position the child such that you have a comfortable approach, because sometimes they would have the chin too low and you may not be having good visibility sitting on the superior side. It has to go superior in a child. And always use forceps and have a control. You can't make it too small because you'll have to make a posterior capsulorhexis in all children, at least below the age of 6 years, to avoid the need for a YAG. So make it adequate sized, about 5.5 millimeters, 5 to 5.5 millimeters is the right size. The posterior capsulorhexis will be important. This is in an adult patient who has a PCO, but in children this is 100% mandatory. The capsule thickness is almost the same, but remember in a child the vitreous upthrust is much more. So you will have to use a good viscoelastic and then do the posterior capsulorhexis. So the posterior rhexis is pretty straightforward to do. Only thing is you'll have to ensure it doesn't go out too large. Now this is a slightly larger posterior rhexis, but it has to be smaller than your anterior rhexis. And while placing the IOL, especially a foldable lens, direct the leading optic haptic junction into the bag between the anterior and posterior caps, because instead of dialing, you just want to be able to tuck these haptics below the optic. This way the IOL will be in the bag and well centered. So in intumescent and pediatric rhexis, both of these are challenging, but use of a good viscoelastic, investing in a good rhexis forceps and some modification of technique can go a long way in getting a consistent rhexis. Thank you.
Thank you, Dr. Haripriya, for joining in from your course and delivering this talk. So I have finished mine there and yours, so they're expecting you there. This retrieval maneuver, one point which I have noticed it, I have noticed it, where when you are trying to retrieve it, if you are going to go slow, it tends to go further into the periphery. So if you catch just next to the point of tear, and you're decided that you're going to pull inwards, pull briskly. Don't be scared that it will go to the periphery. Slower you are, the more it will go to the periphery. And the placement of high molecular weight viscoelastic should be outside this, not in the center. Should be in the mid-periphery or beyond that area of tear, which will flatten out that area. So these are two things which I have found.
Actually, whether you pull it slowly or fast, it's going to go in the direction that you want it. The advantage is when you pull it fast, you don't give your time for yourself to get scared. Because initially when it starts moving, you're not very sure which direction it's going to go. So if you pause, then you lose control. So if you go fast, you just don't think about it. You just pull it. And it is going to go in that direction.